Hello friends, let's proceed with the 10th chapter in John Murtagh's General Practice Handbook. This is about depression. Depressive illness, which is probably the greatest masquerade in general practice, is one of the commonest illnesses in medicine and often confused with other illness. Untreated depression can result in disability and death. The most feared outcome is suicide. It is present in at least 17% of patients who present to GPs and has a 12-month prevalence of 5% and a lifetime risk of 15%. It is often unrecognized, yet moderate to severe depression is as disabling as congestive heart failure and with a morbidity comparable to coronary heart disease. Further, depression is the leading cause of disability for all conditions among both sexes, both in Australia and worldwide. The lifetime risk of suicide in patients diagnosed with depression is 6%, and treatment halves the risk. Despite being treatable, 60% of sufferers have not used any form of health service in the previous months. Lack of awareness, stigma, and shame on behalf of the patient contribute to this. Of those receiving treatment, three-quarters will be managed in general practice. As Whiteford notes, it is clear that the main focus of activity aimed at reducing the burden of common mental health disorders in Australia is in primary care. Specialist mental health services play a supporting but not central role. Depression is a chronic relapsing organic brain disease. Its mean onset is at 27 years of age. However, 40% of sufferers present by 20 years of age. The average duration of episodes is 3 to 4 months, and 40% of patients will relapse within a 12-month period. The cause of depression is multifactorial, having biological, psychological, and social factors. Mood disorders in general have a strong family tendency, and the risk of developing a depressive disorder can be thought of in terms of a stress vulnerability model. That is, an individual may have a genetically determined vulnerability, and if enough stress is endured, a mood disorder may result. Those who are more genetically vulnerable require less stress, but if enough stress is applied, any individual can develop a mood disorder. A significant characteristic is that it impairs thinking, leading to pessimism with negativity and a loss of drive and productivity. There are 6 clusters of depressive symptoms. Mood, like sadness, anhedonia, and irritability. Then vegetative, sleep, appetite, and sexual drive. Cognitive, that's related to attention, memory, and self-worth. Impulse control, suicide, anger, and homicide. Then fifth cluster is behavioral, that is related to motivation, interest, and tiredness. The sixth one is physical, that is headache and constipation. So these 6 clusters are very important when we are analyzing a patient with depression. A useful working rule is to consider depression as an illness that dampens the 5 basic innate activities of humans. Those 5 basic activities are energy for activity, sex, sleep, appetite and thirst, elimination of waste. We'll proceed further. Classification. The DSM-5 classification divides depressive disorders into major depressive disorder, disruptive mood regulation disorder, persistent depressive disorder, and premenstrual dysphoric disorder. Other specified and unspecified disorder categories allow for diagnosis of those patients who fall short of the various diagnostic criteria. Major depressive disorder includes those disorders with one or more major depressive disorders. Excluding criteria include any previous mania or hypomania, and the episode not being attributable to a psychotic disorder or a substance or medical condition. Major depressive disorder is subclassified with coded cause and severity specifiers. These include mild, moderate, and severe, with psychotic features, in partial remission, and in full remission. A significant subtype of depression is dysthymia, which is a chronic mild depression lasting at least 2 years but not fulfilling the criteria for major diagnostic disorder. For other subtypes, refer to chapter 68. Let's move on to the diagnostic approach. The diagnosis is based on the history and mini mental state examination. The two key criteria for major depressive disorder in the DSM-5 are pervasive depressed mood and marked loss of interest or pleasure, otherwise referred to as anhedonia, persisting for at least 2 weeks. So those major criteria that we have to elicit in patient when we are taking a history are the pervasive depressed mood and marked anhedonia. They should be present for at least 2 weeks duration. Other criteria include sleep issues, fatigue, lack of energy, poor concentration, and feelings of worthlessness. In general practice setting, have a checklist of these symptoms to work through with the patient can be a useful part of the assessment of the depressed patient. Questions to assess level of depression. What do you think is the matter with you? Do you think that your feelings are possibly caused by nerves, anxiety, or depression? Can you think of any reason why you feel this way? Do you feel down in the dumps? Do you feel that you are coping well? Do you have any good times? Has anything changed in your life? How do you sleep? Do you wake early? What time of the day do you feel at your worst? Where would you put yourself between 0% and 1%? Have you felt hopeless? Do you brood about the past? What is your energy like? What is your appetite like? Are you as interested in sex as before? Do you feel guilty about anything? Do you feel that life is worthwhile? Has the thought of ending your life occurred to you? Do you cry when no one is around? Two particularly good questions are: in the past month, have you been bothered by the fact that you feel down, depressed, or hopeless? In the past month, have you often been bothered by the fact that you have little interest or pleasure in doing things? So, these questions are very important questions when we are eliciting the possible symptoms of depression. And at the same time, we have to direct our questions in order to rule out other mental disorders. Inquire about substance use and abuse, anxiety, psychosis, manic or hypermanic episodes, intimate partner violence, bereavement, and postpartum depression. Important differential diagnosis. Important differential diagnosis or organic disease to consider are malignancy, especially of lung, brain, pancreas, and blood or lymphatics, early dementia, congestive cardiac failure, endocrine disorders like thyroid disease, menopause, liver and renal failure, infections like infectious mononucleosis, neurological like multiple sclerosis, Parkinson, adverse effects of medication, anemia, systemic lupus erythematosus, and cerebrovascular disease. Then let's move on to read about the diagnostic guidelines for major depressive disorder. So, at least 5 of the following 9 symptoms with anhedonia and or depressed mood for 2 or more weeks. So, the diagnostic criteria are depressed mood and anhedonia. Either one or both should be present. Then, sleep changes like either increased sleep or decreased sleep. Guilt or worthlessness, decreased energy, impaired or increased concentration, change of appetite and weight, psychomotor retardation or psychomotor agitation, and suicidal ideation. So there are 9 symptoms are there, and at least 5 symptoms should be there to diagnose a major depressive disorder. They should be present for 2 or more weeks. And most important thing is depressed mood and anhedonia. At least one should be there to diagnose depression. Screening investigations to consider: full blood examination, thyroid function tests, blood urea and electrolytes, vitamin B, vitamin D, folate, blood glucose, urine toxicology, CT or MRI are useful investigations. Depression scales. Depression scales are useful both to detect potential mood disorder and to monitor an individual patient over time. Scales commonly used include K10, a distress score, DASS 21 or 42 for depression and anxiety symptoms, and PHQ-2 questionnaires. Somatization. Another issue with depression in the primary care setting is recognizing somatization patients who present without obvious psychological symptoms. Non-specific symptoms such as insomnia, prolonged fatigue, headache, nausea, and musculoskeletal pain are common presentations in people with depression. Studies suggest GPs find it challenging to identify these patients and that using self-reporting patient screening tools can help with identification. Key facts and checkpoints. Depression is common, serious and treatable. Depression is a chronic relapsing organic brain disease. It may coexist with anxiety disorders, stress, both physical and mental, and substance abuse disorders. 1 million Australians live with depression, compared with anxiety, which is 2 million. And 8 lives are taken every day, of which 6 are men. The cause of depression is multifactorial and can be thought of in terms of a stress vulnerability model. Somatizing patients without obvious psychopathology are common and difficult to recognize and manage. It is strongly associated with an increased risk of suicide, a fact that demands risk assessment. Depression in the elderly. The rate of antidepressant prescribing for Australians over 80 years of age is higher than of any other age group. Despite this, depression in the elderly is underdiagnosed. Depression can have bizarre features in the elderly and may be misdiagnosed as dementia or psychosis. Agitated depression is the most frequent type of depression in the aged. Features may include histrionic behavior, delusions, and disordered thinking. Depression is often missed in the elderly because it is atypical and less expressive, and patients tend to be ashamed and reluctant to admit it. A useful clue can be a change in sleep pattern. Medical illness is also an important precipitant of depression in the elderly. Older patients may have more side effects from medications, especially nausea, dizziness, falls, and hyponatremia. They also tend to have only a modest response to antidepressants, and if medications is used, a low initial dose and slow increase is recommended. Psychological therapies can be useful but tend to be underused. In contrast, depression in children and adolescents. Sadness is common in children, but depression, although not as common, does occur and is characterized by feelings of helplessness, worthlessness, or despair. Parents and doctors both tend to be unaware of depression in children. Major depression in children and adolescents may be diagnosed using the same criteria as for adults, namely loss of interest in usual activities and the presence of sad or irritable mood, persisting for 2 weeks or more. In children, irritability may be more prominent than sadness. The other constellation of depressive symptoms, including somatic complaints, may be present. Examples include difficulty in getting to sleep, not enjoying meals, poor concentration, and low self esteem. Poor motor skills and family instability are an association. Depression can present as antisocial behavior or as a separation anxiety, like school refusal. Although suicidal thoughts are common, suicide is rare before adolescence. Depressed adolescents are a difficult challenge for the general practitioner. Effective engagement and establishing rapport in a youth friendly environment is critical. Perinatal depression. This term refers to depression occurring either in the antenatal period or in the 12 months after delivery. It affects 9% of women during pregnancy and 16% after the birth, and affects the well being of the woman, the baby, and significant others. Anxiety is likely to be as more common. Women at risk of perinatal depression include those with previous mental health problems, those who do not have support, and those who have been through difficult times, like family problems, abuse, or loss, or who feel isolated either by distance or culture or both. Because it is so prevalent, routine screening is recommended by the Beyond Blue guidelines. This involves implementing the use of Edinburgh Postnatal Depression Scale, a validated screening tool, at least once, preferably twice, both antenatally and postnatally. Asking permission and explaining the process before implementing the screening is helpful. Women at higher risk will require more intense screening and monitoring. If perinatal depression is identified, the GP should take into account the individual woman's context, her family and cultural setting, and use a family centered approach. Because of the intense emotions involved in having a baby, establishing a strong therapeutic relationship using an open collaborative approach and active listening techniques will help to develop trust, confidence, mutual respect, and empowerment. Psychoeducation should be provided an appropriate follow up and continuity of care with a coordinated team approach. If a woman or a baby is at risk, urgent referral is recommended. Pharmacological therapies can be used in pregnancy, but the benefits need to be balanced against the risk of both mother and fetus. Psychosis in perinatal depression is fortunately rare but does occur and requires urgent psychiatric assessment. Then let's move on to management of depression. Important consideration from the outset are: is the patient a suicide risk? Does the patient require inpatient assessment? Is referral to a specialist psychiatrist indicated? Suicide assessment. Data from Australian Bureau of Statistics illustrate the levels of suicide in Australia over the 10 years to 2019. International self-harm is the 13th leading cause of death in Australia, but the 10th leading cause in males. 75% of all suicide deaths in Australia were males. The national rate is 12.9 suicides per 100,000 per people. The rate of suicide in men has risen over this period from 17.5 per 100,000 to 19.8, and in women from 5 to 6.3. The median age of people who suicide in their early to mid 40s. If the symptoms are major and patient appears in poor health or is a suicide risk, referral is appropriate. The importance of putting these safety issues at the beginning of the management process is reflected in the set a pace model of treatment proposed by Mahi et al. To clarify the risk of suicide, appropriate response ask about suicidal thoughts, any plans that the patient is having, lethality of their supposed plans, means of suicide, past history of attempts to suicide, and suicide of family member or peer. Low risk, fleeting thoughts of self harm or suicide, but no current plan or means. Discuss availability of support and treatment options. Arrange follow up consultation. Timing of this will be based on clinical judgment. Identify relevant community resources and provide contact details. Medium risk. Suicidal thoughts and intent, but no current plan or immediate means. Discuss availability of support and treatment options. Organize reassessment within 1 week. Have contingency plan in a place of rapid assessment if distress or symptoms escalate. Develop a self-plan, a prioritized written list of coping strategies and sources of support to use when experiencing suicidal thinking. Then high risk. So patient is having continual or specific suicidal thoughts, intent, plan and means. Ensure that the patient is in the appropriate safe and secure environment. Organize reassessment within 24 hours and monitoring for this period. Follow up outcome of assessment. So this is very important when we are approaching a patient with depression and when we are suggesting management as a general practitioner. So the patients who are having medium risk, we must organize a review in 1 week. If the patient is at high risk of getting a suicide, then we'll have to reassess the patient within 24 hours, and especially we have to assess the appropriate Safety and security of the environment. A useful suicide risk assessment is the sad person's index. A score greater than 7 represents a very high risk that demands careful attention, including referral to an acute psychiatric service. The suicide rates in Australia, which demonstrate two peaks in males, are illustrated in this figure. So, sad person's index or suicide risk assessment. Risk factors are the being male sex. You give one score for that. Then age, if less than 20 or more than 45, then the patient is getting a one score. If the patient is already diagnosed as having a major depressive disorder or in depressed mode, then 2 marks. Then there were previous history of suicidal attempts, then again 1 mark. Then excessive drug use like ethanol or other drug use, give 1 score. Rationality of loss, like the patient is having psychosis or severe depression, then give 2 marks. Then separated, loss of spouse or other single, give 1 mark. Then if the patient is determined of a suicidal plan, give 2 marks. Patient is having no community backup or generally isolated, give 1 mark. And if the patient is having chronic illnesses, give 1 mark. So all these risk factors are getting marks. The higher risk or for the factors that we are giving 2 marks are if the patient is having determined suicidal plan or the patient is having psychosis or severe depression and the patient is having major depressive disorder or depressed mode. If there is concern about suicide risk and treatment of supervised hospital outside hospital, provide closer supervision and considerable support, and prescribe drugs that are less toxic in overdosage, like mainserine or fluoxetine. If tricyclics are prescribed, useful guidelines are that dangerous medical complications occur with an equivalent dosage of 1000 mg 40 tablets or imipramine and a higher risk of death with 2000 mg or 80 tablets. After safety is established, and this will need to be continually reassured at each consultation, the two other aspects that need to be developed early in the process and also continue in through the long-term management of the patient are educating the patient about his or her condition and individual situation and establishing therapeutic relationship. So education and maintaining a therapeutic relationship are most important two factors. Then assessment include characterizing the symptom profile, calibrating the severity and chronicity, rating scales can be employed here. Then corroborating if possible and appropriate. Medical and psychiatric comorbidities and context. Significant psychiatric, physical and social comorbidities of depression are common. These include 49% suffering and anxiety disorder, 40% reporting child sexual abuse, 57% child physical abuse, 42% having been at some stage afraid of their partner, and 72% reporting a chronic physical condition. Putting the patient's condition into his or her individual psychosocial and medical context will improve the assessment. Considering coping styles and the social, financial, and occupational consequences of the patient's condition and situation. This assessment is often spread over multiple consultations. Treatment. The basic treatments are outlined by the acronym PACE. PACE. These are safety, education, and therapeutic relationship. SET. Then A is for assessment. We have to assess, characterize, calibrate, collaborate, and consider. Then PACE, PACE, psychological therapy, antidepressant treatment, combination, or ECT. Psychological, including basic psychological treatment such as advice on lifestyle changes, problem solving, guided self help, structured supervised exercise, and supportive counseling. All patients with depression should be offered these types of support. More sophisticated techniques such as cognitive behavior therapy or interpersonal therapy may be used for selected patients and should be undertaken only by appropriate trained doctors or therapists. Another option that some patients may prefer is computer based cognitive behavior therapy programs. CBT involves teaching patients new ways of positive thinking, which have to be relevant and achievable for the patient. Patients need to be able to recognize their own negative cognitions, including their anxieties and worries. Antidepressants. Antidepressant medication is useful in moderate to severe depression or when depression has an anxiety disorder. Co-diagnosis. Antidepressant therapy should be avoided if bipolar disorder is suspected, and screening should be actively conducted for symptoms of past or previous mania. In terms of which drug to use, there is no single drug that is preferred. Most antidepressant agents are approximately equal in efficacy, although individual patient response may vary considerably. However, SSRI, selective serotonin reuptake inhibitors, are considered to have the most favorable balance of benefit to harm in moderate to severe depression. Sexual dysfunction and gastrointestinal side effects are common. The most toxic agents are the tricyclic antidepressants and the monoamine oxidase inhibitors. Other suitable first line agents are reboxetine and mirtazapine. SSRIs have a relatively flat dose response curve, but dose increase with the recommended range is reasonable if there is a partial response at a lower dose and no troublesome side effects. Combining different antidepressants or augmentation with lithium or antipsychotics should be done with psychiatrist supervision. Serotonin and noradrenaline reuptake inhibitors appear to be more effective in treating severe depression symptoms and may be a suitable first line option here, but otherwise, adverse effects may limit them to second line treatment. Tricyclic antidepressants and monoamine oxidase inhibitors are considered second line because of their side effect profile. Then few drugs are being listed here with the usual initial dose and the maximum doses. I will read out the usual initial dose. The selective serotonin reuptake inhibitors like citalopram can start with 20 mg and 10 mg if the patient is more than 65 years old. Escitalopram is 10 mg. Fluoxetine 20 mg can go up to 80. Fluoxamine start with 50 mg, then can titrate up to 300 mg. Paroxetine starting with 20 mg can go up to 60 mg. Sertraline can start with 50 mg and go up to 200 mg. Then serotonin and noradrenaline reuptake inhibitors like desvenlafaxine start with 50 mg can increase up to 200. Duloxetine starting 60 mg can increase up to 120 mg. Venlafaxine starting with 75 mg can go up to 375 mg. Other drugs are mirtazapine starting with 15 mg can increase up to 60. Acometaline starting at 25 mg can go up to 50. Reboxetine starting with 2 mg can go up to 10 mg. The benefit of medication in moderate depression is equivalent to psychological therapies such as CBT or IPT, and both of them are around 20% more likely to achieve remission than placebo. In severe depression, medication is more effective than psychological therapies, though the latter in addition may help reduce relapse rates once remission is achieved by medication. So for moderate depression, we start with psychotherapy, either cognitive behavior therapy or interpersonal therapy. For severe depression, we start with the pharmacological treatment, and once the patient achieves remission, start psychotherapy. The aim of treatment of depression is to achieve and maintain remission. Remission is defined as having minimal or no symptoms of depression. And a good way of asking patient about this is to ask, do you think you are back to normal self? When using antidepressants, if a response is not evident in the first 2 weeks or there is an inadequate response in 6 weeks, then it is unlikely that this medication will work for this patient and a treatment change is recommended. So, if there is no response by 2 weeks or there is inadequate response in 6 weeks, we have to change the medication. A washout period will be required before a second medication is tried. Patient needs to close monitoring early on the course of treatment and weekly monitoring may be helpful. If remission is not achieved in 3 months, then consider a second option and continue active treatment. A combination of antidepressants and psychological therapy can be considered if there is an inadequate response to either therapy alone. Combining medication with psychological therapy is more effective than either therapy alone in moderate or severe depression. ECT or electroconvulsive therapy is a relatively safe and effective therapy for severe and resistant depression. There is some risk of transient short term cognitive impairment and long term memory impairment, and this therapy is reserved for severe depression when pharmacotherapy has failed. It is administered under the supervision of a psychiatrist. Possible indications include psychotic depression, like delusions, hallucinations, melancholic depression, unresponsive to antidepressants, severe postnatal depression and psychosis, substantial suicide risk, ineffective antidepressant medication, and or previous response to ECT, severe psychomotor depression, refusal to eat or drink, depressive stupor, severe personal neglect, immediate referral for hospital admission is necessary in most of these circumstances. The course, which is highly variable and individually tailored, is about 8 to 12 sessions given at 1 to 3 sessions a week. The most common initial ECT method is unilateral therapy. Transcranial direct current electromagnetic stimulation, where no anesthetic is required, is a procedure being explored as a less invasive alternative to electroconvulsive therapy. Useful management guidelines. Mild depression, go for psychological therapy. Moderate depression, psychological therapy and or antidepressants. Severe depression, antidepressants and then consider addition of psychological therapy to maintain remission or consider psychiatric review for ECT. When to refer? Uncertainty about diagnosis. Inpatient care obviously necessary. So the patient is having high suicidal risk. Then severe depression. Inability to cope at home. Psychotically depressed with a delusion or hallucination. Substantial suicidal risk. Failure to respond to routine antidepressant therapy. Associated psychiatric or physical disorder. Depression in the elderly can be a difficult problem, where diagnosis, including dementia, is doubtful. Children with apparent major depression. Choice of treatment. The choice of treatment should be determined together by doctor and patient, and the best outcomes are likely when a good therapeutic alliance is formed. The patient's preferences are taken into account. To quote the RAN ZCP guidelines, the greatest benefit of the therapeutic relationship, which enables agreement on treatment selection and continuation. A strong determining factor on patient preference may be the patient's own previous experience of treatments or his or her perceptions of treatment results in other people may know or potential adverse effects of the proposed treatment. Whatever the treatment is chosen by the doctor and patient working together, the choice is less important than persisting with treatment. As the Beyond Blue guidelines state, it is not so much what you do, but what you keep doing it. This is why consistent follow up and monitoring is so beneficial. Complementary and alternative therapies. Complementary and alternative therapies are widely used for depression. It is estimated that only 50% of Australians who are depressed receive an evidence based professional intervention. A larger drive for this is public's belief in complementary and alternative therapies. One study showed 57% related vitamins, minerals, tonic, or herbal medicines are likely to be helpful for treating depression, compared with 29% who regarded antidepressants as likely to be helpful. Despite this, none of these therapies is supported by evidence, though some warrant further evaluation. Because of their common usage, nearly half of Australians have used complementary medicine in the previous 12 months. Actively inquiring about use of any complementary and alternative therapies in patients with depression is advised. One of the more commonly used and extensively researched alternative therapy is St. John's wort, which has had mixed results in the research of its effectiveness. One review in the literature suggested it is effective in mild to moderate depression, though two others suggested it is not. Regardless of its effectiveness, it has a lot of medication interactions. These include HIV medicines, warfarin, digoxin, anticonvulsants, oral contraceptives, and triptans. Because of this, care needs to be taken with using St. John's wort, including when switching between different preparations that may contain different amounts of active compound. Let's move on to serotonin syndrome. While rare, serotonin syndrome is a serious adverse reaction to use of SSRI and other serotonergic medications, including St. John's wort. Symptoms must coincide with the introduction of or dose increase of a serotonergic agent. Drug can be considered here, including antidepressants, opioids, especially tramadol, stimulant drugs, illicit drugs, antiemetics, lithium, and selgiline. Other causes such as infection, substance abuse, or withdrawal must be excluded. At least three of the symptoms or signs attributed to the syndrome must be present, like mental state or behavior changes, that is, like agitation, confusion, hypomania, or seizures, altered muscle tone, like tremors, shivering, myoclonus, and hyperreflexia. Next is the autonomic instability. It can manifest as hypertension, hypotension, tachycardia, fever, or diarrhea. So, this triad is very important in diagnosing serotonin syndrome. Mental state or behavior changes, altered muscle tone, or autonomic instability. The offending agents should be withdrawn immediately and supportive therapy initiated. Refer to the emergency department. Continuing treatment. If antidepressant medication is used in and remission is achieved, it is recommended that it be continued for a minimum of 12 months for an initial episode and for 2 to 3 years in subsequent episodes or in those at higher risk of relapse. Risk factors for relapse include residual depressive symptoms, 2 or more prior episodes in the past 5 years, 3 or more prior episodes, history of severe prolonged depression, especially with psychosis or attempted suicide, comorbid medical problems, and life stressors. When remission is achieved and the treatment is in the maintenance phase, ongoing monitoring of treatment effectiveness, tolerability, and adherence is recommended. Encouragement to persist with the treatment will improve compliance. When ceasing medications, withdrawal reactions are common, so a gradual withdrawal by halving the dose each week may help reduce these. So that's all about depression in John Murtagh's General Practice Handbook. Let's meet up with another chapter. Thank you for listening. Bye.